I think the last presentation goes very well with ours. This is cannabinoids in the hospital and long-term care settings, something that's very near and dear to my heart. I work as a hospitalist. I work on the geriatric floor. I work on a number of other wards. So I am often called upon by my colleagues who have patients who come in who are already being prescribed medical cannabis saying, what do I do? And I also am involved in house calls, and I go to a number of long-term care facilities, retirement homes, and I often get patients there asking me, what do I do? Or I have directors of medical care centers saying, how do I get my patients on cannabis? Because I hear it works. I want to try it. Everything else has failed. So here are my disclosures. I have done a number of presentations on behalf of a number of different producers. I do some consulting work, and I am not currently a member of the CMA, just to put it out there. So there's a few things that we want to talk about today. Talk about why it's important to develop a policy surrounding the use of cannabinoids in both hospital and long-term care settings. Identify the logistical and practical considerations around this. And I'd like to offer you an approach that I use when I have patients coming into the hospital acutely, as well as giving you some ideas how to approach it when you have elective surgical patients. As we heard, patients were, well, there's a tremendous amount of patients enrolled in the ACMPR system. We are having increasingly exponential growth in the ACMPR system, and more of those patients are elderly. In my personal patient population, the average age is 52 years old, and we see that increasing as the years go on. So what I'd like to do is introduce you to George. George is an 82-year-old male that was referred to me by his family physician for chronic pain secondary to rheumatoid arthritis. He lives with his daughter and her family, and he has mild cognitive impairment, rheumatoid arthritis, hypertension, coronary artery disease that is stable. And when I saw him, he had some trouble with ongoing chronic pain. He did not want to start opioids. He had tried everything else, and he also had sleep disturbance. He's tried all the other traditional, interventional, and complementary and alternative medicine therapies with moderate success, but he wanted a better quality of life. Over the period of 5 months, I was able to titrate him up to 0.7 milliliters of CBD oil twice a day and 0.4 milliliters of 1-to-1 in the evening. He had significant improvement in his daytime pain control, improvement in his sleep. He was able to increase his participation in day-to-day activities. And when he didn't have access to cannabis, he had definite rebound symptoms. He didn't have withdrawal symptoms, but definitely rebound symptoms. Now, the issue, and why I'm presenting George to you, is because his daughter and her family wanted to go away to Florida. George did not want to go down to Disney World, and the decision was made that he should be put into a respite center. So he was going to go for a short duration into a residential care center. Now, when his family went to the care center to say, you know, this is George, this is what medications he's on, we'd like to leave him here for a week or two with you, they reviewed his medications, and when they saw that he was on cannabis oil, they freaked. They said, whoa, 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 we don't want him on medical cannabis, we don't know what this is, we don't know where it's coming from, so he's more than welcome to come in and spend some time with us, but he can't be on medical cannabis. So this is something I'm sure that a number of clinicians have encountered in the past, where you have long-term care managers who just do not want patients even being considered for medical cannabis entering into through their doors. So this is something that I found in the papers recently. It was an article about how they were approaching it in the United States. I wonder if this is the future of medical cannabis here if we don't have a medical system. It's an article that says, this shuttle bus goes straight from the retirement home to the dispensary. and it talks about how a dispensary sends a bus to a retirement village once a month and brings them to get their medication. But obviously this is not appropriate for all of the reasons that we have discussed ad nauseum already today. So we have to realize that cannabis is a medication. It's different from all other medications that are out there. It's a plant-based product that has medicinal properties, that is being used for medical purposes. It can also be used for recreational purposes, spiritual purposes, lifestyle purposes, but it's also a medicine for a good number of people. Now, unfortunately, there's a number of barriers to using medical cannabis within the hospital and long-term care setting. It is not on formulary. It does not have a drug identification number. We do have to treat it as a narcotic, and that means that it has to comply to certain policies and procedures surrounding narcotics and narcotic dispensing that are already established within long-term care and hospital settings. Also, cannabis is not cannabis. It's not one product. There are literally hundreds of different products out there, different formulations, oils, capsules, dried flower, and some of these preparations need, or some of these products need preparation. They have to be ground into a substance, material in order to be put through a vaporizer. And this means that it has to be the patient who's using it, who may have dexterity issues, will need assistance. And that means that there is going to be involvement by nursing, by other people, in order to help the patient or the resident with that. And the other concern that I never thought of before it was brought up to me is that people are worried about potential effects on other patients. We all say vaporization is a healthier way of using inhaled cannabis, and people said, well, we can't use a vaporizer in a hospital setting or a long-term care setting because we don't know what the secondhand effects of vaporized cannabis is. Does it have any effects? Does it have any potential ability to cause intoxication or impairment in the person who is in the bed or in the room next to them? And that means that we might need a special place for these patients to be able to use their medication. So one thing that is also really difficult when we're talking about cannabis within the long-term care setting is the chain of custody of the actual product, because pharmacies who are within the long-term care settings or hospitals are not able to take medication from a patient and then dispense it because they don't know where it's coming from. They don't know if it's been spiked with something. They don't know if what's in the bottle is actually the same thing that's on the label. And at the moment, pharmacies, as we heard earlier today, are not able to dispense cannabis. They don't have a stock of it in their supplies, so they cannot provide it directly to the patient if it's been ordered or authorized by the attending physician. Now, it is possible, and there are a number of long-term care facilities out there that have created protocols and procedures whereby the patient nominates the care director of the facility as a substitute decision maker. So they can actually receive the cannabis on behalf of the patient, opened in the presence of the pharmacist, and that way there is a chain of custody that has been maintained. So that's one way that the long-term care facilities can get around this tricky issue of supply management or consistency of supply. We talked briefly about difficulties with administering cannabis. Cannabis is considered a narcotic. There's a big N on packaging because it's considered a narcotic by the Health Canada. And we have to approach cannabis the same way that we would approach any other narcotic or medication or opioids, benzodiazepines, etc. Now, we heard earlier also from the Nurses Association that it's a bit tricky. It's a bit unknown whether nurses are actually allowed to dispense cannabis or not. It sounds like some jurisdictions say it is possible, others say it's not possible, that they'll be arrested if they dispense cannabis. But I think that most nursing associations would support nurses who are dispensing cannabis when it comes from a pharmacy and authorized by a physician, and it is within the policies and procedures within the care facility that they're working within. The other thing that can protect nurses or the staff within the long-term care facility is if a patient or the family sign a release or informed consent document, just like we would when we're prescribing or authorizing cannabis in our offices. The other thing is there's no smoking room, and we talked about potential effects or unknown effects of secondary vapor. One way that a couple of organizations have dealt with this is by creating or assigning a negative pressure room that has been made available for residents. And I think that this is something that we're going to have to grapple with even more when legalization for adult use happens, and there's a lot more people who are interested in using cannabis as a lifestyle or for recreation. So long-term care facilities, aside from how we approach cannabis for medical purposes, are also going to have to grapple and come up with policies and procedures how to deal with cannabis for adult use or elderly use. And the other thing is, if cannabis is meant to be vaporized, now, one thing that we know is that in the elderly population, the vast majority of them are going to be using oils. So the vast majority of patients are using cannabis or cannabis products for chronic illnesses. So oils, which have a longer duration of action, are much more amenable to be used, and there's a greater justification to use oils, which have a longer duration of action as opposed to inhaled cannabis. But some patients will still require, as needed, inhaled vaporized cannabis. And for that reason, vaporization may be required in certain patients. As I said before, this means that it requires preparation, and it will likely require preparation by the nursing staff. This means that nurses have to get trained, they have to understand what cannabis is, they have to understand how to grind something up, put it into a vaporizer, not pack it too tightly, weigh it, and this is all time consuming, and we know that our nurses are often underfunded, overworked, and time poor when they have to do so many other things. But when we think about it, there are a lot of other medications that nurses have to prepare before administering to patients, insulin, other injectable or medications, even crushing medications for every patient takes a long time. What's nice is that we do have oils, and oils can be provided either in a syringe or even more useful, they are encapsulated. A number of licensed producers have hard shell caps or soft gel caps and can be seamlessly integrated into a patient's treatment regime, put it into their dosette. So, what happened to George? Now, the long-term care facility that he went to for respite did not have a policy in place to deal with patients who are already prescribed medical cannabis. I negotiated along with the patient's family and the director of the long-term care facility to allow dispensing and administration of pre-filled syringes. So George was getting 3 doses a day, which means that the family had to go out, and the family was going to be away for a week, so he was going to be in care for 7 days. Family had to go out, buy 21 individual doses, draw up all of the doses in advance, give it to the pharmacy so that it would be dispensed for his regular doses. Now, they saw how well he was doing. They saw that it was relatively easy. So following this Holmes experience with George, the nursing staff director discussed with stakeholders, including staff, residents, the medical director, and they undertook to create a policy for allowing patients who were either coming in already on medical cannabis or for patients whose attending physician wanted to start them on medical cannabis. And that long-term care facility now has a number of patients who are doing very well, who are on medical cannabis. So this is one aspect. I want to flip over to the hospital setting. This is Andre. I mentioned I work as a hospitalist. He was a patient that was admitted to me overnight. He's 32 years old, a recreational cannabis user. He says that he's using 1 to 2 grams a day smoked in joints. So he uses 2 or 3 joints a day. And he was admitted overnight with acute pancreatitis. When I saw him in the morning, he was MPO, he had an NG tube, and he was requiring regular IV hydromorphone. And he was also requesting cannabis be used in addition or instead of the hydromorphone. He really did not want to be on opioids because he's had a number of friends who actually became addicted and passed away, unfortunately. So, is there a risk to not providing cannabis in the acutely admitted patient who is already using cannabis on a regular basis? So the main concern that we have is cannabis withdrawal syndrome. We often say, and this is something that has been very well documented, cannabis in general causes us to feel happy, hungry, and sleepy. When we use it chronically, we become tolerant, dependent, and if we stop using it, you get withdrawal symptoms, the opposite of happy, hungry, sleepy. So instead of happy, we become irritable or more anxious. Instead of sleepy, we get insomnia. And instead of hungry, we have increasing nausea or a poor appetite. Usually this is after prolonged or heavy use. And it's the withdrawal syndrome is quite a bit less than we see in a lot of other medications. And the symptoms usually peak after a few days to 1 week, and depending on the chronicity of use and the individual, it can last between weeks and even 1 to 2 months. Now, what I want to bring up is the fact that we have a number of different options here in Canada in terms of cannabinoids, and I always like to bring this point to the fore that cannabinoids is not just herbal cannabis. It represents an entire group of medications, those that have a DIN, a drug identification number, and those that don't. In Canada, we have 2 that are stocked in the pharmacies. Many of them are stocked in most hospital pharmacies, Nabilone or Sesamet, and nabiximols or Sativex. So Nabilone is a THC analog. It's a stronger CB1 and 2 receptor agonist than THC. It is widely available across Canada and is covered under all of the public and private insurance plans and is stocked in most hospital pharmacies. Nabiximols or Sativex is an oral mucosal spray that is extracted from the herbal cannabis plant. It delivers a standardized dose of both THC and CBD. It's quite expensive and not stocked in most hospital pharmacies. So what I would suggest for many people who come in who are already using cannabis, who are either medically or recreationally, who the attending physician is interested in covering or preventing cannabinoid withdrawal syndrome and providing them with baseline coverage for cannabis, is to start them on Nabilone. And usually this is not for people who are just using cannabis on an occasional basis. This is usually for people who use cannabis on a regular basis. If they are using cannabis on a regular basis, I've given you a rough guide as to what the dosage of Nabilone that I have found beneficial in clinical practice. If patients report ingesting between 0.5 and 1 gram a day of cannabis, I suggest starting on Nabilone 0.5 milligrams 3 times a day. If they use between 1 and 2 grams, Nabilone 1 milligram 3 times a day. And if they're using above 2 grams a day, which is a lot, they should be started on Nabilone 2 milligrams 3 times a day. Always be aware that Nabilone can also have side effects, significant dry mouth, somnolence, GI upset, dizziness, and psychoactivity. Because Nabilone is a stronger CB1 and 2 receptor agonist than THC, you have many of the benefits of THC with Nabilone, but the side effects of Nabilone are the same as THC, except even stronger because it binds to those receptors much more readily. And we also have to remember that cannabinoids, by and large, are hepatically metabolized and can interfere with metabolism of other medications. So for all the pharmacists in your room, I'm going to say you are our best friends in the hospital. So please consult with your pharmacist if you're going to be starting someone on nabilone or even medical cannabis. Now, if you have a patient in a pre-op clinic and you're wondering, and you're doing your medication review and your recreational drug review, you need to have an approach with regards to cannabis. You have to ask about this. Not every patient will come out and give you this information readily. It's important to discuss options with patients prior to admission. If they are not using nabilone, at least ask them if they would be willing to use it while admitted. If they're unwilling, ask if they have a vaporizer, ingestible oil, or other non-combustible ways of using medical cannabis. And I think it's important to contract with your patient to use cannabis only with the agreement of the attending physician and the allied health team, because you have to make sure that patients are going to respect the rules and regulations of the institution that they're in. And that also goes for residents of long-term care facilities. Now, what's interesting, when I was doing my research and preparation for this talk, I learned that there's a special regulation within the ACMPR about hospital pharmacies. Apparently, hospital pharmacies can actually have stock of medical cannabis or cannabis oils. A hospital pharmacist, with the authorization of their senior administration, can call up one of the licensed producers and order a quantity of medical cannabis to have within their hospital pharmacy. So if for some reason an attending physician wants to start someone on medical cannabis, they have the option of doing so within the hospital. This is something that I didn't know about. My pharmacy team at Royal Victoria Regional Health Centre, where I work in Barrie, was not aware of, but it's something that I will definitely be bringing to their attention. So what happened to Andre? He was admitted to hospital. He was provided with 1 to 2 milligrams IV hydromorphone, Q 1 to 2 hours as needed. After we prescribed him nabilone, 1 milligram 3 times a day, his hydromorphone requirements decreased significantly so that he was only using 2 milligrams every 2 hours, he decreased from 2 milligrams every 2 hours to 1 milligram every 4 hours, in addition to the nabilone. And that's something else we could talk about, but I think we're going to be looking at that a lot more tomorrow, about the possible opioid-sparing effects of cannabis. So what will allow cannabis or cannabinoid products to be easily integrated into long-term care and hospital workflows? So it would be great if we had a standardized product, standardized delivery system, and pharmacy dispensing. But the most important thing for integrating cannabis into these areas is to establish a strong policy and procedure document that is informed by all stakeholders, that include residents, family, pharmacy, nursing, physicians, etc. So for all physicians, nurses, allied health professionals who have a relationship with either a long-term care facility or a hospital, I urge you to speak with your team in order to prepare a policy regarding cannabis use, because, like it or not, this is something that we have to address, because we will be getting more and more patients who are starting cannabis or who will be using cannabis recreationally or for lifestyle purposes. Just to give you an idea that in the future there are some devices that may make things easier. There are meter dose inhalers, there are meter for dried product, there are meter dose inhalers for vaporized cannabis oils, but these things are not yet available on the market in Canada. Perhaps in 1 or 2 years they will be. Either way, we still need to develop policies and procedures in order to integrate cannabis into the long-term care and hospital setting. So just a few points to leave you with. Long-term care residents are one of the fastest growing groups of patients using medical cannabis. While there are numerous barriers that exist to incorporating cannabis into patients in long-term care in the hospital settings, this can be rectified by creating a document, an institutional policy that includes stakeholders to allow and acknowledge that cannabis is going to be used by this patient population. So thank you very much, and it's always tough being the last person of the day when people are tired and sleepy, but I really appreciate everyone hanging in there.